You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. Be sure to follow the podcast on your favorite app so that you never miss an episode. Today, we're joined by Daniel Bourque, a nationally recognized educator and leader in cardiac ultrasound. Daniel is the program director at the Orlando Health School of Cardiac Ultrasound and Echotechnical director at Orlando Regional Medical Center. With a background in education and a master's in exercise physiology, he brings a rare blend of teaching and quality leadership to the field. Daniel also serves on the RCS Writing Committee for CCI and is an active member of the American Society of Echocardiography. In this episode, we dive into the evolution of cardiac imaging, from 3D TEE to AI integration, along with Daniel's insights on mentorship and building strong, collaborative echo labs. His passion for advancing both people and practice truly sets him apart.
Quality supplies make a difference. At EDM Medical Solutions, we support over 2,000 healthcare facilities across the U.S. with high-quality medical products built for real clinical needs. From ultrasound imaging accessories to surgical instruments and everyday disposables, our portfolio spans women's health, men's health, and the operating room. We've spent over 35 years helping practices deliver safe, efficient, and cost-effective patient care, with the personal support only a family-owned company can provide. Explore our full range of solutions today at us.edm-imaging.com.
On this episode of The Scoop on Ultrasound, we're exploring the intersection of education, clinical precision, and innovation in cardiac ultrasound. Our guest today is Daniel Bourque. He's the program director for the Orlando Health School of Cardiac Ultrasound and also serves as the Echotechnical director and quality improvement coordinator at Orlando Regional Medical Center. Daniel brings a unique background to the field. With a bachelor's in education and a master's in exercise physiology, he's blended teaching, science, and patient care throughout his sonography career. His roles range from running protocol development and quality control meetings to teaching complex pathology through backscanning. He's also an adjunct instructor at the Gulf Coast School of Ultrasound and a speaker for Lantheus Medical Imaging. Nationally, he's presented at major ultrasound society meetings and currently serves on the RCS Writing Committee for CCI. Additionally, he's an active member of the American Society of Echocardiography through the Sonographers Council and other committees, and a graduate of the ASE Leadership Academy. Daniel, thank you for joining us. It's a real privilege to have you here today.
Thank you for having me. I'm very excited to be a part of this.
Let's start with the beginning because your path to sonography isn't really the typical background, we could say, right? What led you from a background in education and exercise physiology into the world of cardiac ultrasound? And how have those foundations shaped your approach to sonographer education and quality improvement today?
So I definitely had a very serpiginous course in getting into ultrasound. It's one of those things where once you find it, you realize how excellent and how amazing the field actually is. I started off as actually a physical educator and knew that when I was in physical education that I always wanted to go back for a master's degree in some form of exercise science. And then once I got into exercise science, I found electrocardiograms and EKG, and I became so fascinated with cardiology. I had never been introduced to it. I always knew about, obviously, the benefits of a healthy cardiovascular system in relation to exercise. But when I saw EKGs, it was almost like learning a different language. And I've always wanted to kind of learn a different language, and I became fascinated with it. And then what that led me to was it led me to stress testing. And then I worked in a stress lab. And then one day when I was in the stress lab, I saw in the corner, there was a machine and they're, taking pictures of the heart. And I'm like, so wait, I can see a PVC on the EKG here. But then when I looked over on the echo, I could actually see the PVC in the heart. So I went from having the tracing to the actual picture. And I'm like, well, that's really cool. So I finished out my master's degree. I worked in the field in strength conditioning for a while, but I was always kind of trying to figure out a way to get back into cardiology. So right around the time that the economy kind of took a downswing in 2009, I had to go back for something because my role was going to be kind of absorbed as a physiologist in the practice that I was working in. So I said, you know what, this is my chance now to go into echo. So I found a program in Hartford, Connecticut that was run by Richie Palma. And I just absolutely, when I found it, I sat in and I just started looking, and it's like everything started to just completely make sense. There's a lot of things that I've studied and had difficulty understanding in the past, but for whatever reason, when I got into echo, everything just started to kind of fit all the pieces, all of the things that I had learned in the past from all the different pathways just started to make sense to a point where not only did I understand them, but I could actually communicate those facts in a conversational way. And that's something that I've kind of taken, and tried to take into my educational practice from there.
So interesting how different people arrive into sonography. Your background is unique, but we've had other guests too who have such unique backgrounds. And it seems like sonography just tends to captivate you with its beauty, right? With the science behind it. It's just a really fascinating field. Now, let's talk about TE. For many sonographers, it's one of the most technically demanding and clinically impactful tools in their arsenal. From your perspective, though, what makes TE such a powerful tool in complex cardiac cases, and where do you see it offering the greatest advantage over transthoracic echo?
The thing with TE is that, you know, more so sometimes than echo is that once you get to the transesophageal, you've had a lot of testing and workup to lead to that point. So you're already aware that there's going to be some complexity in the pathology. So, when we use examples, mitral valve is probably one of the more common things that we do in our facility. As good a job as the echo can do with kind of the gateway into assessment of the pathology, there's limitations with the imaging from a resolution standpoint, from an evaluation standpoint, that you can't really do just good surgical planning with an echo. When you get to the transesophageal, now what happens is that when you get into that room, you have improved resolution, you have proximity of the probe to the heart. The three-dimensional technology kind of pops off of the screen, so you have more robust analysis that you can do, uh, and it really leads into a better quantification. For example, we had a case, just recently when I was in the lab 2 days ago, where you look at the echo looks like it's mild, maybe moderate MR. We even did the transesophageal, and just by the color Doppler, which is where most people kind of view and quantify regurgitation visually, it looks moderate. But when you start factoring all of the other things into it from a technical standpoint, you can see the leaflet mobility. You get a better idea of the impact of the cardiomyopathy on what it's doing to the leaflet and to the annulus itself. We have more advanced quantifications that we can do. So by seeing the mitral valve better, we can actually do volumetric assessments. Instead of just looking at the diameter of the annulus, we can actually look at, the complete area, and we can calculate stroke volumes. And then the three-dimensional technology is far better on a transthoracic. So we can, identify, flails, and we can identify gaps and all the things that go into that surgical planning. But also, we do a lot of interventional work. So structural heart is a major thing. So with transesophageal, if you're evaluating somebody for a mitral clip, it's far more robust. You can't see the left atrial appendage on a transthoracic if you're evaluating somebody for a Watchman device, or even intraoperatively for a Watchman device. And then the other thing is you have a collaborative effort. So in the room, typically, you've got anesthesia, you've got a nurse, you have a cardiologist, you have a sonographer. So what I found also with transesophageals is that as you're doing the case, there's a very collegial and collaborative environment where you're kind of looking and you're diagnosing and you're assessing everything. But everybody in the room has some contribution to the care of the patient and to also the evaluation of the patient. And that's really the other thing that kind of separates with a transesophageal, especially in the pre-procedural planning.
Oh. Now, in high acuity environments, consistency is everything, right? Ecolabs that implement structured quality programs like routine protocol reviews and backscanning consistently report lower interoperator variability and higher diagnostic confidence. Your work reflects that commitment, of course. So, how do you maintain high standards in TE performance and interpretation across your clinical teams? And how do things like bi-monthly teleconferences or structured peer feedback play into that process?
So, there's almost two different avenues. As much as we do transesophageal, the pathology and the quality assurance has to reflect both transesophageal and transthoracic. The thing with being a sonographer is the transesophageal quality is a lot of times driven by the pathology. So there's not always set protocols that you do in the essence of what we do for transthoracic. A lot of times the transesophageals become very focused. So we have the benefit in our facility, and this is something that's becoming much more widespread, of having advanced imaging cardiologists that drive these procedures, which is excellent. Our job as the sonographer side to make sure that we're aiding the physician and that we're training our sonographers appropriately is to making sure that before the sonographer goes into the pathology, they have an understanding of what assessments and pieces of information that they need to get, because there is not as much time in a transesophageal to do the assessment while the probe is in the patient. It's not beneficial to the patient. It does add a little bit more stress to the procedure, especially on the anesthesia side, because they have to keep the patient sedated longer. So a lot of times what we do is, for example, if we have a mitral case and we have mitral regurgitation that we have to really assess, we have, 6 or 7 different things that we have to make sure that we get. The sonographer, before they go into that procedure, make sure they're keeping track of that information for the cardiologist to make sure that they have the information to robustly assess that. So that quality goes into it. And then post-processing wise, between the cardiologist, myself, and the sonographer who is in the transesophageal, we review the measurements to make sure that the data makes sense. Because there's complexities. I mean, it beyond even the scope and the time of this talk
Yeah.
to get into. There's exceptions and there's measurements that work. Sometimes they don't work. And what the more measurements and information that you get, the more accurate decisions that you can make. And then what you end up doing is you're weighing the data. So, echo is as much an art as it is a science. And sometimes the measurements don't add up. You have 6 measurements, 4 of them say, yes, it's severe. 2 of them say that it's not. But how important were those 2 measurements? How accurate were they versus the 4, and vice versa? So there's that team approach and that understanding of the data that the sonographer has to have before we package this and hand this to the physician. And then the bi-monthly conferences kind of highlight the pathology. So what we try to do with our system is, twice a month, and then there's one CME that's associated with it. We review, multiple topics. So, we'll talk about aortic stenosis. We'll show case examples. We'll talk about, and what we try to do as part of the learning environment is we try to foster as positive a learning environment. So we know that people are going to be making mistakes. And the goal is not to harp on the mistakes. The goal is to focus on, what did you do good about the study? What pieces of information did you get that were beneficial? And then start to look at, okay, we have this batch of information that's excellent. However, this is maybe 1 or 2 things that you could do. And people have been very, very responsive to that. Um, there are instances where if you put people on blast and, they're not ready for it, they're not aware of it, you're not going to garner trust. And that's something that we value very, very highly. And we found that we've had very good reception. People have been okay with having their studies up and having their name that's associated with it. And there was almost a sense of pride that goes along with that, because we take very much care into the person who's doing the evaluation. And one of the things that we say is, hey, we were not in the room when you did the study. So we can't judge what the patient condition was, what the environment in the room was. However, these are some things that you can do that would probably help to make this study go from being, an A to an A plus, or a B to a B plus, and so on.
That makes sense. I love how you talk about that collaborative factor, right? Of building the people up, not tearing people down. I think that, of course, contributes to a positive culture within the team. Now, still talking about team collaboration, a lot of facilities, if not almost every facility in this country, faces high volumes, right? And burnout is a big topic. So when you have that pressure of the high volumes, what advice would you give to managers or leaders that are worried that that sort of team collaboration is just breaking down because people feel like they're doing too much. How do you preserve that so that the quality doesn't decrease as you're taking on more work?
It's definitely a balancing act. I feel like, what has been done at our lab, we have walked that fine line very well, because you're trying to walk the line of getting all of the imaging studies that you need to get done in a timely fashion to promote, movement throughout the hospital, because there's obviously patients who are higher acuity, patients who need to be sent out so they can get the beds. I mean, that's a real thing. Patients are constantly flowing in and out of the hospital. So you have you'll walk into 60, 70 echoes, which we have done in the past. What you have to do first is there has to be a communication from leadership to the sonographers to let them know that this is an environment that we want you to be in.
Mm.
There has to be that it's no longer, it's a privilege to work in a lab. At this point now, the way that we've kind of looked at it is we have to create an environment that people want to work in.
Right.
And that's how you're going to get the most out of people these days, because there are so many shortages. I mean, listening to other, some of your podcasts in the past, Dr. Schramm and others who have spoke about the significant sonographer shortage. We've started the school on the basis that we have a significant shortage. I mean, 70% of facilities are without proper lab staff. We have been lucky that we've been able to retain and keep that staff, and we've had leadership that has supported us in getting the positions for us to be able to maintain staff. So that's part of it too, is that you can't always work lean, because burnout is one of those things that you can't predict when it's going to happen, but it's going to happen if you're doing in an 8-hour shift, if you're doing 10, 12, 15 studies. That's not a pace that you can maintain. I mean, the injury rate, we know how high that is. That's talked about ad nauseum. Um, and the mental part is what's starting to now kind of be looked at, because when you're starting to hurt and you're starting to do so many studies, and then you're starting to get pressure from administration to say, we got to get this done for discharge. We got to get this patient out. We got to get this. Every patient becomes a priority, and then nobody's a priority.
Right.
So that kind of all washes over. So it has to start from the leadership. You have to let the sonographers know that we're following a protocol to make sure that we're protecting the sonographer, and then also we're protecting the patient. That's the part that kind of gets forgotten in all of this, right?
Yeah.
We're talking about healthcare, and all we focus on most of the time is, how many echoes we have to get done, how many sonographers we're missing, but we're forgetting about the patient. And when we're focusing on is getting a specific number of echoes done, we're realizing that there's a family member that's on the other side of that table that is demanding and should get a quality echo on top of it. And you can't do that if you're cutting corners, if you're doing echoes in 15 to 20 minutes, and you're not, promoting the environment that a sonographer wants to do their best in, because what's in it for them? They're just going to have to do another echo, and they're going to get squeezed even more, and they're going to get pushed even more. And that doesn't work. It just, people end up breaking. We as a lab, what we have done is we've followed IAC guidelines. If you're in an 8-hour shift, it's 6 to 8 echoes. There may be times where we may need to ask you to do 9 if we have a higher volume, but volumes fluctuate constantly. So we have people that are willing to stay because we have set standards to protect the sonographer and to create that environment that they want to be in.
If you are high-level disinfecting your ultrasound transducer, it's likely you're soaking the probe or using an automated HLD device. But there's a better option out there. TriStel Old can high-level disinfect your transducer in just 2 minutes and costs under $3 per cycle. Sound too good to be true? Request a brochure today and learn why so many practices are switching over to TriStel Old. Visit us.edm-imaging.com/TriStel. That's TRISTEL. And now, back to the show.
That makes sense. I mean, that's so important, right? To, like you just said, protect the environment that they're in so that they'll want to be there. And to not forget that there is a human, a patient, right? That's at the center of this conversation. It is far too easy to forget, especially when we have such a burdened healthcare system at times, right here in the US, to forget that this is about people, right?
Sure.
Now let's shift to what's next. I think the audience would love to hear about 3D TE and fusion imaging. We talked a lot about AI, and now we have AI-driven EF calculations, all these things reshaping how we perform and interpret cardiac ultrasound. And a 2023 study actually in Circulation Cardiovascular Imaging noted that 3D TE improved pre-surgical valve repair assessment by nearly 30% compared to 2D alone. So, how do you yourself, being on the field, being actively involved in education, how do you see technologies like 3D TE and AI itself shaping the future of cardiovascular ultrasound? And what's been your experience thus far incorporating these into real world workflows?
So we've tried to be very early adapters of 3D. There's been different iterations of how it has come out, and honestly, the best piece of advice that I ever got was from a gentleman named Rick Meese, and he was a very big 3D guy, and this was in the early stages of us adopting it, and we were in the same boat right now. We were in some labs maybe looking at saying, well, 3D is good, but there's limitations for the image. There's all this other kind of stuff. But we were kind of in that boat. And, he sat me down, he looked at me and he said, listen, if you learn how to do this, you're going to be an invaluable member of wherever you are. And it's going to advance your career in ways that you have never even imagined. He could not have been more dead on when he said that. It has completely changed because what it does is you have a completely different appreciation of what imaging is. You have a better understanding of the structure of the heart. And, and three-dimensional imaging is not just that 3D data set that you look at. What we have tried to do in our lab for simplicity is we've tried to take 3D and make it look like just basically multiple 2D images. For example, if you take a good 3D data set for a mitral valve, you can look at the mitral valve in all the views, but you can use the two-dimensional imaging to dissect it. So it's like using a complex X-plane. Well, you can go medially to laterally, and you can assess little portions of the leaflet to identify where the exact piece of pathology is. It allows you to do better measurements. It allows you to see all of the planes of the valve at the exact same time, which is why the surgical planning goes along much better because, we're limited with just that thin slice of probe that we get when we're looking. We kind of we'll advance the probe, we'll move the probe or rotate the probe, but we're limited with what we get. And if we don't catch that specific angle, we may miss a little piece of that leaflet that's torn. And we've seen this in multiple cases where, just a little advancement of the probe wasn't enough. But then when we do the 3D, we say, oh, did you see that perforation? We had a case like this just the other day. Like, did you realize that leaflet was perked? And we didn't see it till we got on the 3D because we missed that little piece of the angle on the two-dimensional end. And that's just in mitral valve. I mean, with tricuspid valve, you can't do structural heart procedures without three-dimensional imaging. So I'd say now it's come to the point where it's not important to learn 3D. It's essential, especially if you're in an advanced lab because you're not going to be able to function. And that's just on the transesophageal side. If you're on the transthoracic side, it's really honestly the same thing. I mean, the technology is advanced so much now that you can do, in complex cases, you can do planimetry of an aortic valve to get a valve area instead of, you can do your continuity, but it just helps to shore that up. Mitral valves we can routinely get mitral valve areas on two-dimensional imaging, but 3D is so much better. It's the same pieces of information, but you have the ability to really get to the points of those, leaflet tips. And then the 3D volumes are much more robust. The literature has proved that in the early iterations. And, we're trying to do more 3D volumes, especially with the automated 3D, which ironically has automated intelligence in it, which people don't realize. There's AI in those 3D volumes that you're getting to help for border detection. People have been using AI in echo for years, at least 10 or 12 years, and it probably didn't really realize it as much. And I know there's that big fear about, AI is going to take over my job. I've had this conversation with so many other people, and I honestly shake my head. And you have to embrace the technology. It's not you're not going to be. I'm going to say this emphatically. No one is going to be replaced in echo by AI. AI is going to help you to do your job. It's going to help you to do your job more efficiently. If anything, it's going to limit our injury potential because it's less time that we're going to have to spend on the probe because a lot of these measurements we can do with our hand off the probe. We're already seeing that. The advancements that we've got in AI that have done with strain have limited the inter-observer variability. As you had mentioned, it helps with surgical planning. Some of the mitral valve programs that can actually map the mitral valve and kind of look at, annula area, leaflet length, leaflet height, all of those things that go into surgical planning. That's all AI. It's consistent, reproducible data and reproducible information that's used all the time. And it's helpful to, again, who in the end game is going to benefit the most. The patient's the one that's going to benefit the most. There's plenty of echoes that are going to be out there to be done, and I feel like I just want to shout from the hills about how important AI is and how beneficial it is, and it's not going to take our jobs away. It's going to help our job.
Right. AI, of course, is a big topic in healthcare and imaging because of the technological component, right? And how you just mentioned, I think it's interesting that AI has already been there, right, to a certain extent in certain areas for 10 to 12 years. And that's fascinating. It's just now all the attention is on it with this AI spring that we're seeing. And we've had other guests talk about this, and of course, they've agreed with you that they don't think it's going to take people's jobs. It's here to assist the clinician, right? And to really enhance the patient care experience as well, make us go faster, more efficient. Now, what would you say, however, to the detractor that says, well, but you see these programs and they're guiding people now who, or I should say clinicians, who are not sonographers on conducting ultrasound? What tells you that soon they won't be doing advanced imaging? Do you foresee that? Or what response do you give them that you're like, no, we still need to have that sort of expertise and the program's not going to reach such a level?
No, because as much as you have to guide somebody to the image, and as much as the AI is going to tell you where to go with the image, there's still a skill set that's associated with this, and I don't think people realize how much of the skill this is. I look at this in our program itself. I look at the balance between what I'm giving them from a didactic standpoint and what they're going to get from a skill set in clinicals, and I honestly place a heavier emphasis on the clinicals in terms of what's going to make them a sonographer. A sonographer that cannot get images is a worthless sonographer because there's nothing that they can do. They can know everything
Mhm.
that they can about imaging, but if they can't take their hand and put it on the probe and then get that image, even if the AI is telling them where to go, they still have to get the image. So unless the AI is actually getting a hand from somewhere, putting it on the patient, and then manipulating the probe such that they can reproduce an image, that's the only way that things are going to be taken away. And there's still too much of a human interface with the AI. The AI is helping us, but the AI is not doing for us. And that's what the kind of thing that I tell the detractors. Yes, we have people that they're using this in other countries who are not practitioners but they're doing limited protocols. They're not doing truly advanced imaging with these. They're looking at basic evaluations in countries where they don't have the same level of healthcare, and to say this is somebody that, hey, it has severe mitral stenosis. Let's screen them for it. Let's screen them for it and things of that nature. And that's really where that's being used. But, we see the point of care world. I think the point of care world is very important to make sure. The most important thing I see with the point of care world in that is that you have to teach people to understand what the limitations are, and to not comment on so much that they think is there based off of the patient presentation symptoms and what they see in the history, and they try to make the ultrasound fit that category. It really kind of has to be the other way around. You have to work with one information that you have, and then let the imaging flow based off of the protocol that you've established and based off of the information that you're getting. Because if you have terrible images, there's no way that you can comment on, RV dysfunction or RV dilatation, or there's a P. None of those things actually work. And that's something that we try to impart to our fellows that do the point of care that I've worked with in the past, to say, hey, just let's know what the limitation is, but that you can still get great information that's useful, but it's not going to be, 150 things that you're going to put on a report that are going to completely, give you the same amount of detail that, another imaging modality could or may.
I think that's a great breakdown and explanation. I mean, it's true. I feel sometimes those outside of sonography really don't truly understand the level of expertise necessary to do that, right? If they're not as familiar, even in certain clinical areas, really, it's the truth. And there is such a level of depth of knowledge necessary and experience to be able to carry out these complex exams. It's really not as simple, I think, as sometimes even those who are worried, maybe they're students, or they're thinking of becoming sonographers and they're worried, they don't really understand there is such a level of knowledge necessary to do it. So I think that's a great explanation. And even with point of care, we actually recently had a guest, Dr. Victor Rao, and he talked about the importance of training in point of care ultrasound. And one of his specialties is training physicians in under-resourced countries who, like you said, are adopting this because their healthcare systems don't have the necessary imaging infrastructure. And yet he was still saying how training is very necessary. You cannot simply just start deploying, point of care ultrasound machines all over the place and think that it's just going to work like that. The training is necessary for the sake of quality and for patient care, right? And the quality of
Absolutely.
care. Yeah.
Absolutely.
I love to wrap up by talking about growth, for sonographers who are looking to expand their skill sets. They want to move into other roles, within the lab. We often hear that leadership in sonography doesn't always mean a management title. This is something our previous guests had mentioned too. It can also mean contributing to protocols, mentoring peers, or engaging in committee work. So, what advice would you give to sonographers who want to move into advanced modalities like TE or take on leadership and educational roles like you've done?
So there's a couple of different avenues that you can go down. In order to really get into the leadership part, you really have to go a little bit outside yourself.
Hmm.
So that kind of advancement as sonographers, we're so used to having quiet dark rooms where we talk a little bit with the patients. But if you want to get into the more of the leadership modes for echo, or just even ultrasound in general, a lot of that stems from mentorship. Is one of the areas that I see as probably being a very important thing going forward. ASC has done a great job with their mentorship program, where they bring in new sonographers and they place them with more seasoned sonographers who've been in the field. I've taken a part of it. It's extremely rewarding, and you can kind of help guide people. Doing talks and lectures in just even in your facility, and if you have a fellow program, cardiac fellow program, or any fellowship program within the ultrasound area, just working with them is advancement in itself because now you're doing education. But then also, one of the things I think that's going to be very important going forward um, is the mentorship in departments where you're actually training and onboarding people. Because what we're starting to see now is that the level of sonographers that are kind of coming on board, we're getting much greener and newer sonographers that are coming into these facilities, and they do require a little bit of a longer onboarding process. And there's a little bit of a higher level of patience. So there's going to be a bigger demand for educators, and I think we will probably end up seeing more of that, where you actually have to spend a little bit more time with somebody instead of just 30 days with somebody who's training. The complexities of the labs with all the measurements and procedures that we're doing these days, it takes a little bit of a longer time and commitment to onboard sonographers. So I can see more facilities kind of adding that. It's even part probably of the advanced sonographer role, which we're seeing more people, ACSs, we're starting to see more ACSs come in. That's being more viewed as a leadership role. So I, encourage people to, to sit for that exam if you have the qualification for it. It's a great test. It's a great way to, expand your knowledge. It's a great way to, justify and certify yourself in the field. And also getting involved with local societies. It doesn't have to just be ASC. I mean, obviously, ASC is the gold standard when it comes to volunteering. There are so many opportunities to get involved with ASC, and I don't think people realize that there's different levels of volunteer opportunity that you can do. You have micro volunteers where there just might be some surveys that you're kind of taking a part of, or there might be just little things that they have you review, all the way up to the committees and the chairs. And I think most people just think that you have to be a committee and it's a year commitment. They've expanded that significantly. SDMS is kind of the same thing. There's opportunities to, not just in the echo world, but in the general and vascular and in OB, SDMS has multiple opportunities. So getting involved with the national societies, but your local societies, we've seen a little bit more of a growth of that. And even ASC is starting to, place a bigger emphasis on, growth and expansion of local societies. We've seen that. And that's a good place to get started. And it's just, that creates your networking. So there's so many things, but I think it has to start with getting outside of yourself and getting outside of your comfort zone just a little bit. And then just continuing to learn, because the learning isn't done once you're in the field. That's it. It's, this is an evolving field. And,
Right.
I've heard from other people, including myself, it takes 5 years for you to get really situated once you even graduate. So from graduation to 5 years, that's really when you get comfortable, in the field to feel like you're gonna be able to do a good evaluation, to do right by the patient, be able to do more things on your own. And I'd argue that number is actually probably growing a little bit more as we've advanced, some of these modalities and some of these assessments.
Well, I think that number you just gave is very comforting to the early career sonographers, right? The 5 years, if they're within that 5 years and they're, still freaking out, feeling like they don't know what they're doing, but it takes some time. And that's great to hear. And it's true, it takes some time to settle. I mean, I love what you said about always learning, always growing. I think that there are so many opportunities in sonography in particular, regardless of the specialty that you're in, with the societies too, so many opportunities to grow. And every single guest that we've had, or they've been asked, how do you grow? What you mentioned, mentorship, that is something that every single one of them has mentioned. It's just so important to have a mentor or a few mentors, right? Who are really pouring into you as a sonographer so that you can grow as a clinician and then become a leader if you choose to go down that path. So I really do appreciate you taking time out of your busy schedule once again to be on the show, Daniel. Thank you for what you're doing at Orlando Health, training the next generation of sonographers, and for everything you're doing with the ASC to promote the advancement of cardiac imaging.
Thank you, man. This is great. I enjoy it, and, you guys are doing wonderful, and I appreciate the time. Thank you.
Thank you for listening to this episode of The Scoop on Ultrasound. Subscribe today to be notified when new episodes are released, and visit our website, us.edm-imaging.com, to learn more about who we are and what we do.